With an aging population, clinicians are more frequently encountering patients with atrial fibrillation who are also at risk of intracerebral haemorrhage due to cerebral amyloid angiopathy, the result of beta amyloid deposition in cerebral vessels. Cerebral amyloid angiopathy is common among elderly patients, and it is associated with an increased risk of intracerebral bleeding. In patients with recent lobar intracerebral hemorrhage and a need for antithrombotic therapy because of the comorbid atrial fibrillation, determining the presence and severity of cerebral amyloid angiopathy should be part of the decision-making process, wherever to start anticoagulation after intracerebral hemorrhage. Given the paucity or randomized clinical data to guide stroke prevention strategies, we have today the opportunity to discuss with Dr. Charidimou his view on the use of pharmacological or non-pharmacological approaches to decrease the stroke risk in this challenging patient group.
I would like to have the great honor and pleasure to introduce Andreas Charidimou. He's an instructor in neurology and a senior resident at Boston University Medical Center. Dr. Charidimou's research has focused mainly on cerebral amyloid angiopathy and aiming to improve diagnosis and defining risk of hemorrhage and dementia, with the aim also to integrate it with the novel biomarkers into clinical practice. Very nice to meet you, and many thanks for joining us, Dr. Charidimou. I would like to start with the first question. You are a very well-recognized expert in cerebral amyloid angiopathy. Do you mind to start with by explaining us what is this condition and why is it so important in terms of consideration in a patient with a stroke or intracranial hemorrhage?
Thank you so much for your kind introduction. I'm thrilled to be here and discuss about amyloid angiopathy for as it's relevant for Prestige AF. And what is cerebral amyloid angiopathy? At the neuropathological level, is essentially a condition which is characterized by amyloid deposition into the small vessels of the brain. So it's a microangiopathy or a small vessel disease. Now, this amyloid protein is deposited primarily on the superficial vessels of the brain, leptomeningeal arteries and cortical penetrators. And as the disease progresses, essentially it renders these small vessels very fragile in a way that when you have other risk factors, for example, minor trauma or anticoagulants or high blood pressure or blood pressure fluctuations, one of these vessels might burst, leading to an intracerebral hemorrhage. This, of course, happens in the minority of patients with cerebral amyloid angiopathy. In most patients, it's essentially asymptomatic, or we might see evidence of what we call neuroimaging markers of amyloid angiopathy, microbleeds, siderosis, white matter hyperintensities.
Right, many thanks. So in this kind of setting, why is it very important to consider amyloid angiopathy in a patient management, especially in a patient with ischemic stroke or hemorrhagic stroke or on anticoagulant?
So historically, the field first recognized amyloid angiopathy as a neuropathological condition, and then through clinical autopsy studies in the 70s, they realized that some patients with lobar hemorrhage have severe amyloid angiopathy. With the advent of neuroimaging, we're able to diagnose this condition better in routine clinical practice. And we noted that patients who suffer from an intracerebral hemorrhage due to amyloid angiopathy, they are at increased risk of bleeding. And as I said before, with neuroimaging now, we can see little evidence of this condition, even in patients that they never had a significant bleeding event. For example, as you mentioned, patients with ischemic stroke. Because this condition traditionally is considered to be very hemorrhagic, there is concern that if you diagnose a patient with amyloid angiopathy who had an ischemic stroke, and that patient needs anticoagulation, there is a lot of concern whether this is a safe choice or if the anticoagulant will push this patient to suffer an intracerebral hemorrhage.
Many thanks. maybe some of our colleagues in the audience would like to understand when we can start suspecting amyloid angiopathy. What are the signs and symptoms of severe amyloid angiopathy?
Yeah, in the past 10, 15 years, we appreciate more that the clinical manifestations of amyloid angiopathy are really, they have an expanded spectrum. So amyloid angiopathy clinically can present with a stroke presentation, and this is a lobar intracerebral haemorrhage, so a stroke syndrome. Or it can present with transient focal neurological episodes, typically positive phenomena that they look like TIAs, but they're a bit atypical. And in these patients, we often find acute convexal subarachnoid hemorrhage. Or you can diagnose patients in the memory clinic setting, so patients with cognitive impairment or Alzheimer's disease, that you get brain MRI and you see neuroimaging markers of the disease. Apart from that, it can be an incidental finding. For example, a patient with a migraine or an ischemic stroke who gets a brain MRI to work up that syndrome. A clinician might see, again, neuroimaging markers of amyloid angiopathy, but that's incidental. And we don't know if there is significant clinical relevance of that finding.
Many thanks. So you mentioned before that severe amyloid angiopathy can significantly increase the risk of intracranial haemorrhage, and then also maybe other intracranial relapse. What do you think are the main important features in terms of neuroimaging, in particular MRI, that can be related to this higher risk of relapse in terms of intracranial haemorrhage, and then to what extent?
Yeah, but very good question. Again, with the widespread use of brain MRI and some clinical MRI-based research, the field has now realized that the increased risk of future hemorrhage is not uniform in amyloid angiopathy, but certain features can use to identify patients with higher bleeding risk. And just to link this with neuropathology, what it comes down to is the idea that you need to have severe amyloid angiopathy or amyloid angiopathy with certain neuropathological characteristics like vessel wall cracking and leptomeningeal disease to suffer a hemorrhage. Based on MRI, we can phenotype the patients for the future risk of hemorrhage. For many years, the presence of lobar microbleeds was the dominant MRI marker that people would associate with future risk of hemorrhage. But in the last 5 to 8 years, another MRI marker emerged, which is called cortical superficial siderosis. This is basically blood-brain down products that they get deposited into the cerebral cortex or the subarachnoid hemorrhage. And it seems that the presence and extent of siderosis is the most important predictor for future hemorrhage. Just to give you some characteristic examples, a patient with a lobar hemorrhage due to amyloid angiopathy has around 7 to 10% risk of bleeding per year. Now, if that patient does not have siderosis, the risk is down to 5%, whereas if that patient has multiple areas of siderosis, the risk can be up to 13 to 20% per year. So the message is that really the bleeding risk in amyloid angiopathy is not uniform, and we have some imaging tools to stratify that risk. And for many patients with amyloid angiopathy, the risk might be in the range of 5 to 7%.
Many thanks. So you and your colleagues have recently published the very important update to the diagnostic Boston criteria for severe amyloid angiopathy, and this was in 2022. Can you summarize, can you explain to us what are the main changes that you made in this update, please?
Yeah, absolutely. So the Boston criteria have been used historically to make a clinical MRI diagnosis of amyloid angiopathy, and we haven't changed the core philosophy of the criteria in that in the absence of neuropathology, which is the gold standard, a clinical diagnosis can be made as probable amyloid angiopathy, which essentially what requires is having evidence of 2 or more superficial bleeds, microbleeds or siderosis or intracerebral haemorrhage, in the absence of any deep haemorrhages, because deep haemorrhages are a marker of another common small vessel disease called hypertensive arteriopathy. These criteria were proposed in the mid-90s, and they were then validated with small cohorts in 2010. And what we have done in the recent update is that we have gathered a huge data set around the world, and we have included many imaging markers, and we tested them to see if we can increase the diagnostic certainty. The notable changes is that we have included non-hemorrhagic markers for probable amyloid angiopathy, white matter hyperintensities in a certain pattern, and perivascular spaces that you can see on clinical routine MRIs in the cerebral white matter. So now you can diagnose this condition in patients that have a combination of hemorrhagic and non-hemorrhagic markers, which kind of increased our net of capturing these patients. And another notable change is that the cortical superficial siderosis that I mentioned before has a more central role in that you can diagnose a patient with probable amyloid angiopathy only based on the presence of siderosis. To make the formal diagnosis, the patient needs to have known deep haemorrhages. An important point about the new Boston criteria is that in order to diagnose probable or possible amyloid angiopathy, a prerequisite is that the patient needs to present with a amyloid angiopathy-related syndrome, lobar haemorrhage, transient focal neurological episodes, or cognitive impairment. Otherwise, there is no clinical relevance of applying the criteria. In other words, in clinical practice, if, say, you have a patient who presents with an ischemic stroke, who gets a brain MRI, and you see 3 lobar microbleeds, you cannot diagnose formally these patients with probable CAA. This is a patient which has 3 lobar microbleeds, and we don't really know if it fulfills the criteria for severe enough amyloid angiopathy to make the formal diagnosis, because it comes down to over-diagnosing amyloid angiopathy, and it also comes down to clinical relevance. And we did that on purpose in the Boston criteria for 2 reasons. First, most of the patients we had present with a clinical syndrome. And secondly, we wanted to avoid clinicians around the world over-calling and over-diagnosing amyloid angiopathy in patients that, for the most part of their life, amyloid angiopathy will not cause any problems. So that was the whole idea, which is relevant to this, to the question in these studies.
Great, many thanks. So in case we have a patient with a severe amyloid angiopathy, atrial fibrillation, and a previous intracranial haemorrhage, what can be the risk of ischemic stroke in this patient?
Yeah, and I think that's the easy part of the equation, because we have very good data from both observational studies and randomized trials in the field of AFib and ischemic stroke, and we know that we have good scores like the CHAD-VAS score. So you can stratify the risk of a future stroke according to these scoring systems. Now, in patients with intracerebral hemorrhage and amyloid angiopathy, we know that maybe for any given CHAD-VAS score, the risk of ischemic stroke in the future might even be higher compared to other populations. And based on large observational studies, let's say for a CHAD-VAS of 2 or 2.5, the risk of future ischemic stroke in a patient with CAA and intracerebral hemorrhage is around 10 to 15% per year. So it's really substantial. That's the first part of the equation. I think you had a follow-up question, right?
You are reading my mind. So exactly, the same question is, the patient is also AF, so there is also a consistent risk of thromboembolism. Do you think that there is something that we can stratify in terms of risk?
In terms of the risk of thromboembolism?
Yes.
Again, yes, I think it can be very well stratified according to these scoring systems that we use in AFib, irrespective of what other neurological conditions the patient have. So we have a good grasp of the risk of future thromboembolism, including an MI or even peripheral disease.
So we have a consistent risk that can be very, very significant. So what is the evidence then to start an antithrombotic in this patient?
Yeah, so we know, again, that pretty strong evidence that anticoagulants bring the risk of future thrombotic episodes, especially stroke, down by 0.6 in relative risk, so more than half that risk. Now, the other part of the equation that I mentioned is that obviously you need to take into account the risk of haemorrhage, because as we discussed, if you have amyloid angiopathy, the risk of haemorrhage might be potentially increased. Now, that risk of haemorrhage, if this is a patient that you have an MRI, can be stratified again based on the MRI findings and based on the clinical syndrome that this patient presents with. Again, as an example, if this patient is suspected to have amyloid angiopathy based on incidental finding of microbleeds, I wouldn't take that into account in my decision-making. And we can discuss later the evidence behind that. If a patient has a previous history of lobar haemorrhage, then I will stratify the risk based on the presence of siderosis and lobar haemorrhage, how well controlled the blood pressure is. But this is basically guesswork, because the risk of future hemorrhage is based on observational and highly biased data. The reality is that we don't have good evidence to make these decisions in clinical practice. So there is a huge need for randomized trials.
Absolutely. So therefore, when or based on which evidence or in the current evidence, would you think a patient with atrial fibrillation and some features of amyloid angiopathy can really be unsuitable for anticoagulation?
Again, we don't have absolute evidence. So what I'm going to say, I just go by intuition and based on biased observational studies, but I would feel that patients at the highest risk of future hemorrhage with amyloid angiopathy, so patients with disseminated siderosis, patients who already had a hemorrhage, a lobar haemorrhage, and patients with uncontrolled blood pressure, all of these three features in combination might be unsuitable for oral anticoagulation. But this will still keep me uneasy, because I would know that these patients have a big risk of an ischemic stroke. So I feel like I'm choosing what type of stroke this patient is going to suffer in the future. But that's only the subpopulation that I'm worried about in clinical practice. Multiple areas of siderosis and a previous lobar haemorrhage.
Well, many thanks. So we're talking about these observational studies. Based on what really these observational studies are telling us regarding the risk of vascular events in patients with different clinical CAA subtypes.
Yeah, we have the best event rates that we have according to the clinical subtypes of amyloid angiopathy is basically for future bleeding events. We don't have good data for ischemic events. If a patient presents with intracerebral hemorrhage, the risk of future bleeding is about 7 to 10%. If a patient presents with a convexal subarachnoid hemorrhage, that risk is equal, if not higher, so it's around 10 to 13%. A patient who presents to a memory clinic with dementia or memory impairment and has evidence of amyloid angiopathy, that risk is much lower. It's around 3% per year. And patients that present with an ischemic stroke or TIAs, and they have microbleeds on their brain MRI, the risk of future hemorrhage is 1%. Also, patients that they're healthy and they just get a brain MRI for any other reason, so the so-called general population, when you see lobar microbleeds making you suspicious for amyloid angiopathy, the risk of future hemorrhage is even lower than 1%. It's about 0.3 to 0.5%. So that's the range overall according to clinical syndrome. And this future risk of hemorrhage can be further stratified, as we discussed, according to the imaging phenotype.
Okay, so it is quite well known that the risk of having another intracranial hemorrhage is higher in patients who have a lobar hemorrhage. So can you tell us about how severe amyloid angiopathy can affect the risk of recurrent haemorrhage in patients with a lobar intracranial hemorrhage?
You mean according to the imaging?
Yes.
The imaging markers?
Yeah.
Yeah, we discussed that the overall risk of a future bleed in a patient with CA-related hemorrhage is in the range of 7 to 10%. And then if you really stratify this risk according to the presence and extent of siderosis, let's say a patient does not have any siderosis, then the risk is around 5%. If you have siderosis present, that risk doubles. It goes up to 10%. And if you have multiple areas of siderosis, which is a small subset of patients, I have to say, it's like 10 to 15% of these patients, then the risk goes up by 4 times. So it can go up to 20%. And again, this concerns small subgroups of patients. This is how these are the data we kind of know about the spectrum of risk in patients with lobar hemorrhage and amyloid angiopathy.
What we know for the other type of hemorrhage, the deep intracranial hemorrhage?
Yeah, so the deep intracerebral hemorrhages, which are spontaneous, so without any vascular abnormality underlying them, they're mainly due to hypertensive arteriopathy, which is the other small vessel disease. And we know from observational studies that the risk of recurrence is much lower in those patients and is in the range of 1.5% per year. There is an intermediate category that they have mixed hemorrhages. So let's say they have a lobar hemorrhage and deep microbleeds. So in that case, the cause is likely not just amyloid angiopathy, but the combination of the two arteriopathies. We know that those patients have an intermediate risk of bleed in the range of 5% per year. So the stratification is lobar ICH according to CAA is around 10%, with all the ramifications we discussed. Deep hemorrhage with hypertensive arteriopathy is 1 to 2%, 1.5%, and intermediately the mixed hemorrhagic category is around 5%.
Okay, many thanks, really. So, what can be the role of the microbleeds that in terms of affecting the risk of intracranial hemorrhage in patients with or even without severe amyloid angiopathy?
Yeah, the way that the thinking around microbleeds has shifted over the last few years is that microbleeds is a great diagnostic marker. So it essentially allows us to apply the Boston criteria, that allow us to find evidence for hypertensive deep arteriopathy, but they're not very good markers, or at least not as good as we thought when microbleeds were discovered, to inform the risk of future hemorrhage. In patients with symptomatic lobar hemorrhage and amyloid angiopathy, in various studies, when we looked at different imaging markers for future hemorrhage, when you include microbleeds and cortical superficial siderosis in adjusted models, microbleeds are not a predictor of future hemorrhage. They're more a predictor of whether that patient has amyloid angiopathy, not whether the patient has a type of amyloid angiopathy that increases the risk of hemorrhage. Now, in patients that present without any CA-related syndrome, like in patients with an ischemic stroke, we know that lobar microbleeds might not even be due to amyloid angiopathy. They might be due to other small vessel conditions. And we have pretty robust observational data from studies like the CHROMIS-2 in the UK and an international meta-analysis effort showing that the presence of microbleeds, while increasing the risk of hemorrhage in patients with an ischemic stroke, they also increase the risk of a future ischemic stroke. And in fact, if you look at the absolute risk of hemorrhage in these patients versus ischemic stroke, the risk of ischemic stroke, again in absolute numbers, is always higher, irrespective of how many microbleeds the patient has. Always, the ischemic stroke risk is always higher than the hemorrhagic stroke risk. So in that sense, I think this question is kind of settled, at least in the absence of a lobar hemorrhage, that microbleeds should not really affect our anticoagulation decisions in patients with ischemic stroke.
Yes, absolutely, because you explained that there is either way around you want to say the story. It can be the intracranial hemorrhage and then on the other side, the ischemic event.
Yeah.
So you are very involved in clinical trials like Prestige AF, Enrich AF, or Aspire. So at the moment today, do you feel comfortable enrolling a patient with a lobar intracranial hemorrhage and severe amyloid angiopathy into one of these trials?
The short answer is that not only I feel comfortable, I feel thrilled that we have these trials because there has been a lot of therapeutic nihilism in these patients. So many of these patients, we would not even offer an anticoagulation option because of the perceived high risk of future hemorrhage, which in a substantial proportion of patients is not real, is not based on the data, is not there. So I would feel very comfortable including this patient because for many reasons, it's a real dilemma. So 1 in 5 of patients with a lobar hemorrhage have AFib. There is the clinical approach to this question varies if you ask different clinicians. So it's a real clinical question. There is high risk of ischemic stroke, as we know, when you have AFib, especially in patients with hemorrhage. We said 10 to 13% per year, so it's substantial. Plus, we have a very good likelihood of net benefit with anticoagulants, with a reduced of risk by 60 to 65% in these patients. And from small numbers from preliminary randomized trials, the suggestion of harm in that you increase substantially the risk of hemorrhage is not so evident. So really, our patients deserve high quality evidence from randomized trials to guide clinical practice instead of just doing guesswork. So I feel comfortable including most of these patients in trials like Prestige AF and others that are ongoing.
You say you feel comfortable to include most of the patients, but do you think there are some type of ICH and ICH patient with a severe amyloid angiopathy that you would not recommend participating in one of these trials?
Yeah, it comes back to our initial discussion about risk stratification. I will feel not less comfortable, but maybe a bit anxious with patients that had lobar hemorrhage and multiple areas of siderosis. So a way around that is to include all other patients in these randomized trials, so we see the effect sizes and how it affects both the bleeding and the ischemic stroke risk, and then trying to translate those findings in these patients. Or I will feel more comfortable to include those patients in a trial on this topic that has an occlusion device as one of the arms. So again, my anxiety is coming from observational data and empiric evidence. Is not based on anything that we know, because in fact we don't know from randomized trials. But that's the small subpopulation that I would feel less confident.
So generally speaking, this you mentioned about the left atrial appendage occlusion. Do you think that it can be a valid or even a better option for stroke prevention in these patients?
I believe it can potentially be a good option and a valid option. Again, what we're lacking is a randomized evidence. So theoretically, it's a nice option in patients that you don't want to expose them for years and years to anticoagulants because you feel they might be at increased risk for bleeding. And the technology is changing. The need for intensive antithrombotic regimens have gone down from 6 months to 3 months, peri-procedural. And there are small case series in patients with amyloid angiopathy showing that these patients are not at increased risk periprocedurally for hemorrhage. So I think it's a potentially nice option. So we need the evidence to inform us how to use it, in which patients, in which scenario.
Okay. In your routine clinical practice, when you see a patient in your stroke unit or in your outpatient setting, do you send on a routine basis this patient for the closure, for the left atrial appendage occlusion?
Yeah, there are scenarios that we do send them for an occlusion device. And these decisions, I think, they're best made by a neurocardiology kind of clinic or concept where you have a stroke neurologist and a cardiologist reviewing the data that you have for the patient and making a joint decision or making a joint suggestion to the patient. And we're not doing this very often, but patients that we perceive that are at the maximum risk of hemorrhage, or patients that they have high risk of hemorrhage and the blood pressure cannot be well controlled, and you don't want to expose them to 10 years of anticoagulation, we would typically send them for an occlusion device.
Okay, right, many thanks. So we are reaching the end. So many thanks for sharing your really valuable expertise with us today. We are approaching a conclusion. Can you just summarize for us what you currently think is the best management for patients with intracranial hemorrhage and severe amyloid angiopathy, please?
Yeah, so I think the best management is when you're lucky enough and you have a randomized trial open at your center, because then you're going to contribute to generating evidence regarding these patients. And as part of a trial, you're going to closely monitor these patients, whatever treatment they got. If you're in a setting that the trial is not an option, I think the best management is to really stratify the risk of hemorrhage according to the syndrome, imaging markers, and how well high blood pressure is controlled, essentially, and make a joint decision with your local cardiologist. Most patients with amyloid angiopathy, they will be safe on anticoagulants. And I'm talking about patients that they don't have high hemorrhagic burden on their brain MRI, or patients that amyloid angiopathy is made as an incidental MRI finding. But we really need evidence. We really need evidence, and we also need to stop not offering these patients anticoagulants just because there is a perceived high risk of bleeding. So the best management is to be found through these randomized trials and the consortia that is going to pull together all of this data.
Okay, right. Many thanks for sharing.
Thank you.
Take-home messages. The first take-home message is, given limited data from randomized trials regarding anticoagulation in intracerebral hemorrhage patients with probable cerebral amyloid angiopathy and atrial fibrillation, currently the best choice for patients is to enroll them into randomized clinical trials such as Prestige-AF. Take-home message number 2 is left atrial appendage occlusion. There is not enough evidence today to support the conclusion that this procedure is safe and effective in intracerebral hemorrhage patient with cerebral amyloid angiopathy and atrial fibrillation. Finally, the risk of thromboembolism in patients with atrial fibrillation after intracerebral hemorrhage should be carefully weighted, and even if the patient has imaging markers or cerebral amyloid angiopathy, such as cerebral microbleeds, cortical superficial siderosis, and white matter hypertensities.